Welcome back, SUPERSTAT listeners, to a wonderful Christmas-filled episode. Definitely in the spirit over here with our candy canes and lollipop overlay. We're happy that you're here today to talk about what's new happening in the world of lab med. And today we have an interesting topic, one that maybe you don't even know is going on. But in the government right now, there is a Hospice Access to Care and Treatment, otherwise known as Hospice Act, proposed to help improve access to symptom relieving treatments for patients that are enrolled in hospice. This is for what they would kind of consider longstanding barriers to care and palliative. And it really pits together an interesting piece that involves lab medicine, which is transfusion stewardship versus patient-centered care. And as you know, at SUPERSTAT, we are a fan of patient-centered care, but we are also fans of transfusion stewardship as laboratory professionals. And so what's interesting about this Hospice Care Act is that it would allow reimbursement for high-cost palliative treatments and recognize services like palliative transfusions as hospice appropriate. So it removes this forced choice between comfort-focused care and symptom-relieving transfusions. Now, I'm sure we have a lot to talk about as laboratory professionals as we talk about transfusions for anyone on palliative being covered by Medicare services and being something that people are be able to walk in the door and receive. So without further ado, let's get those Christmas bells going and dive in.
Background as a blood banker, because when you think about hospice care and this Hospice Care Act, obviously there's the ethical role, right? There's the emotional impact. We all have families. God forbid that we are ever in this situation, and thoughts to anyone who is in the situation. So we want to be super sensitive in how we approach this and make sure that we're addressing it from the most scientific lens as possible. But really, to start, I'd like to think, start with you all. What is the role of the clinical laboratorian in all of this? And where do we shift from curing and providing a service to really what this act requests from us is providing comfort? Because sometimes when it comes to palliative care, the most important test you can run is actually the test you don't run, right? Laboratorians were trained to optimize accuracy and speed and work on precision and volume. But hospice to me really means we need to optimize the meaning. And Dr. Nelson does a lot of work in this space with elderly care. And she knows that, like I said, value is really in comfort and decision making. And is that test going to make a change in the way you're going to manage that patient? What really intrigued me, what you said in the intro when we talk about transfusion services, is blood is a precious commodity. I mean, unlike any other drug, it cannot be manufactured, it cannot be bought, it cannot be made. It's only available because of the precious donations of other donors. And, because of that, and because so few people who are eligible to donate actually do donate, we want to make sure that that resource is there when absolutely needed for traumas and C-sections and women having babies and people having transplants and surgeries, et cetera. Not saying that this isn't a completely meaningful use of blood products, but I think it's a worthy conversation to have. What do you guys think?
Oh, yeah, you kind of hit on the ethical part of it. With such shortages in blood, do you tend to give more of the units towards people that are continuing on in life or leading towards the end? So that is a kind of a tough call with the shortage that's there, because we are always talking about blood utilization. At least I feel like that every month. I'm always in quality, we're always talking about how we're utilizing these units. Do we need more? Even in the mornings, we're keeping track of how many platelets we have on hand, how many units we have on hand constantly. So it's a tough ethical question. And for me, like hospice care, I didn't realize too that it's not from. I thought it was just the very end of your life, but it's even providing that support even before that point as well. So I just kind of figure out where's the balance, where do you send the unit? So as a blood banker, that's interesting to kind of think about.
Yeah, what is that balance between over testing as a patient safety issue versus a dignity issue? I mean, like I said, the emotional impact is underrated, but powerful angle, because there's obviously going to be a family component and what is that person's wishes. And so obviously you really have to come at this with what is our diagnostic responsibility here, which is hard sometimes.
That's true, because we want our testing to actually impact the patient. And if it's testing that's not going to impact the course of care,
Mhm.
is it necessary? And Dr. Nelson looked like you were right on the precipice of saying something.
I think we have to consider too, though, when we talk about value-based medicine, right? If we're pro value-based medicine and laboratory integration into that space, then the question really becomes like, what matters to the patient segment?
Mhm.
That's how we're supposed to frame part of our trajectory into and our foray into like shared risk and all of these types of things. Is like, not only does it benefit better care, but care comfort as part of care. Remember, we've talked about that, like especially like in our ICHOM courses, a lot about how comfort is a part of that. And then what is comfort? Is it the ability to breathe better toward the end of life? Is it, what I read when I was researching this, there's a lot of papers from like a psychology point of view for the caregiver, like the ability of your family member to receive palliative blood transfusions actually alleviates some of the burden, for lack of a better word, of your caregiver, and it's actually a sense of calm for them, right? Calm is part of care too, and so it's just it's a very complicated issue, where lab is kind of in the middle without knowing it. I mean, before I saw the article about this, I had no idea this was going on. So I think it kind of exposes that we as laboratory professionals have to kind of like pay attention to news sources outside of ourselves sometimes, and like these other divisions as well.
Yeah, and speaking as a person who's had a family member who was on palliative care and thankfully kind of made a 360 and is completely doing fine now. As a family member, lab results, especially if you've got a degree of medical history like us, lab results can often give you like false anchors of hope. So I remember being fixated on numbers like, oh, his hemoglobin improved, or his creatinine got worse, and then all of those downstream effects. So numbers, just family members getting these labs daily, and some labs are repeated several times a day, can unintentionally prolong suffering, especially if the family interpret that as a signal of fighting or something worsening. And so, like you said, if comfort is the goal, are these lab results providing comfort? Or are you actually trying to do something with this? I would hope that, the focus of many of these individuals reviewing this bill is to reframe hospice and the labs involved as contextual information, not promises to the family or the patient.
No, because you raised the great point of how much is too much testing. Because we wouldn't draw like a CBC. There's a limit on how many CBCs we're drawing before we're actually negatively impacting things or giving false hope. But so in this realm, how much testing is too much? It's a good question.
Do you think though, like, do you think from a care equity perspective though, like that's part of the argument?
Well, I wonder, because of health literacy, like, do families understand appropriately the goal of care? And is that clearly discussed? Because, in many circles that we're all in, they talk about how health literacy has to be communicated at like an elementary level. And so I wonder, with families dealing with so much, and, there's an amazing book called There's a Snake on My Head that's written by Misty Spiegel, where she talks about how, if you're afraid of snakes, right? And I don't know if you're in the audience and you're listening, if you're afraid of snakes. If you're afraid of snakes, picture this: if there's a snake on your head, right? And all that anxiety that's building in you because there's a snake on your head. And then imagine I start to give you some really important information. How much of that information are you going to remember? And that scenario, or that picture, is what she uses to describe how most patients feel. They're going into healthcare environments, and they're meeting with doctors and nurses and a lot of healthcare professionals that are using acronyms and words they don't understand, and they're worried and they're anxious and they got to get back to work, or I got to pick up the kids, but I got to be here. And all of these things are going on, and do they actually understand all the information they're being given? So I would ask, not only just from a health equity standpoint, like access to care, the geography, the race, the ethnicity of the patient, also from health literacy. Do they understand, or has it been clearly discussed? What is the goal of my patients or of your family members' care? What is the goal of all this lab work?
Because you mentioned the snake in your head thing, and just even with healthcare training, I have had times where I've gotten news where it just nothing's going in at that point, and we have that training. Mm-hmm. So to be someone that doesn't have that general literacy and to get that news is pretty terrifying. And even just something that when we're educating people about, if you have a strep throat and it's viral, then you don't need an antibiotic. Something as simple as that is hard to educate patients on. But if you pull in cancer, or you pull in something else, or something even more complex than that, it takes a whole lot more to get the point across.
So with that though, I'm going to play the other side of the coin here, because we're doing this. It's a great conversation, right? I mean,
I can see you noodling in your mind.
Over here. So okay. So from a patient perspective though, right? If we take a strictly like value-based medicine type lens approach, where we're saying what matters to the patient, and they say, I want reduced fatigue, I want improved dyspnea, I want enhanced, functional status, I want to be able to attend my son's graduation and feel present. And a blood transfusion, even while they're on palliative, accomplishes that. Then as lab medicine, if we're partnering in those types of case-based scenarios, we are partnering for a value-based outcome, even if it's a utilization, like clutch my pearls moment for us. Mm-hmm. So how do we balance the two? If this passes, what do we do as a community? Or go ahead. Sorry.
No, go ahead and finish your question.
No, I was going to say, or is this one of these instances where we should have been involved at the beginning of this ask? If we would have been more present in the policy, maybe there would have been some specific call outs or some language where lab felt more comfortable. Or is this a place where we should feel uncomfortable? I'm talking too much. I'm going to stop now. But
no, but what you're bringing up is powerful and discussed in so many ways in so many venues, which is lab needs a seat at the table. We need to have a voice. And, if this passes, I would hope that all of our listeners who work in a clinical lab space would have the liberty and the voice in the venue to have such a conversation with their clinician partners who are ordering those transfusions, so that those aspects from a pathology and from a patient and from a clinician standpoint could all be weighed for every single patient. I think the unfortunate truth is labbers are receiving an order and fulfilling a transfusion request. And so for laboratorians listening, do we need to feel more empowered to say to ourselves, why are they drawing blood on this patient again? And call the physician and say, and insert ourselves into that conversation and, maybe say, is this testing aligned with the goals of care? I saw a CBC earlier in my shift, and now there's another CBC, or there's a MAG included in the order set that was ordered earlier today. And now I see another one coming through. And so perhaps, it is a responsibility on us to escalate pathways for us to question utilization and, unnecessary, what could be unnecessary testing. We don't know if it's unnecessary or not, but what could be.
Yeah. And that's why we're part of a larger team. So to play on the other side of what you were talking about, Melody, was just if it's like with the fatigue, but that's giving them better quality of life, giving them that additional moment, that time that's kind of priceless. we're giving that to our patients. So then, I mean, I would say then it is worth it. And there's been this argument with cancer drugs, with different ones that have been developed, where you're spending $30,000 on what might give somebody 6 more months, but what's the value of 6 more months? It's priceless for somebody that's going to get to go to a graduation, who's going to get to see their child swim or get married, and it's those moments that you can't get back and you can't pay for and get more of. So time's something that no one can buy. So it's tough because we're here for our patients and we want them to have the best quality of life while they have it. I mean, if it's extending life out and it's not good quality, then that might be where you kind of draw the line. But if it's giving them that extra moment of quality life, then so.
So do you think then that this exists in some kind of care conference type environment where the patient, like just how we review complex patients as a group together, and all the big brains, we always joke at like the big brains come together and say like, what do we do next? Like just like if we get a tox consult on a patient, and we're thinking of being creative in terms of that, like would it function the same way that, hey, we have this patient who's come in and they really want to pursue palliative transfusion. Can we care plan together to say like what utilization resources, like how many units can the lab actually do this for? And the other thing is like, is it whole blood or pack cells? Like, are there rules for that? Like, how do we handle that? I think there's a lot of care management decisions that would have to be made. Because in my mind, this even works as like an autologous thing where like, I know in the United States, we don't have family-directed donation, but internationally they do. And maybe this is an area where family-directed donation has a place or a home, in the American healthcare system. I don't know. That's a little avant-garde, but I'm just thinking it's such a hard topic to problem through.
Well, and I think it will help laboratories, particularly those in rural communities or small laboratories, look at how you're measuring outcomes today, right? It's not just based on was there a transfusion reaction or did the hemoglobin go up? Like what was the true impact and outcome? And I think the whole topic, the Hospice Act, is interesting. It challenges us to kind of look at the laboratory not just being here to serve, just being here to give a diagnosis or give a result, but being here to, help serve people, and so we have to step back through that compassionate lens, like our friend A.A. Ron said, and, lean in to what is actually going to serve our patient, our community.
Yeah, I think it would help too if we were able to actually have those care teams that discuss the cases, like you're talking about, Melody. We were actually able to see the patient at the end, not the end, but but in community settings, you do get those opportunities. And us running the tests, we really are doing the transfusion. Don't get to a lot of our transfusion medicine people do get to know the patients pretty well in a capacity, but if we got to know them in a more of a different capacity, kind of like our phlebotomy team that's up front. When I get to observe them and that aspect, they build this rapport with their patients. So, and we're not as patient facing, but I feel like if we could find ways to build that rapport to see, wow, Jenny got to spend more time with her kids, or make the Little League game or something to make that connection. And I feel like we do make that around the holidays. Usually in the lab, we have some sort of where we are donating or getting presents or collecting something to where we're actually getting to see our patients a little bit more.
You kind of touched on it a little bit, Dr. Nelson, but what is our risk in, bias of standard orders or cure pathways, or what is our DE&I risk here?
Yeah, it's really interesting. So I don't know. I deep dived on the death doula community for a while. I think I shared some of that with you, Steph, for a while back, where like people have created these amazing like networks where they truly believe in like dying well and like having someone to help fulfill like your goals and what that is for you in your care, much like a birth doula would at your delivery. And so one of the things that I've heard said is like a good death is not about control, it's about being cared for.
Mm.
And so I think when we think about that as a lab, we're in this situation as we talk about like our lens, like our perspective is one of like, we are saving resources, right? We are controlling those resources because we know the huge responsibility it is. You know, you can have a trauma, you could have a GSW, you could have like 300 things come in the door at the same time. And then you have a patient who's dying of cancer, who's been actively dying for, 6 months. And then if you're asking us situational ethics in that moment, and it's a 24-year-old, right, coming in a MVC, like, where are we going to go, right? Like, that unit's going to go somewhere, and if it's the last one, where's it going? I think that's really hard. I think and we make choices like that all the time in healthcare, and it's that not to say that. I mean, I've had people bleeding out in the ER, and somebody calling me saying, "I need a therapeutic transfusion on so and so on the unit," and I'm like, "That's not going to happen right now." Right. So like if we're in that moment and we're already having these moments, what you're alluding to is like, how do we put some structure and some rules in place, right? To make sure that we're not individually making decisions that should be system decisions that are made with care, but also triaged appropriately, and that we can all like know the rules of engagement on.
Right.
What is fair and equitable?
Yeah.
And like, how do we define that here as it relates to like a competing maybe palliative transfusion? I don't know if I answered that right. I feel like I stumbled on that, but
no, it's a good answer, and I think it just kind of takes us further down the rabbit hole, right? Because if you think about, marginalized communities, there are going to obviously be some patients that just due to access or lack of access are less likely to be referred to healthcare or referred later in their disease course. Or, some patients are going to be allowed dignity earlier and other patients are going to be over medicated longer. And so where does the lab fall in helping to manage that with their healthcare partners?
I mean, it's tough. I mean, lab, we're pretty procedure driven, but then do we look with that lens at the procedures that we have in place for the patients that have actually gotten to us? There definitely is disparity in who's getting that preventative care, who's getting those preventative tests, and even who's in more pain and they're not getting the response that they should be getting. So it just makes it tough. You hope that you can get access to care for everyone and that the procedures that we have in place are doing what they need to do. And we do have periodic review constantly for our listeners. So we do look at our procedures, but are we looking at them with the lens of access?
And also understanding that transfusions are symptom reliefs only. So, it's not going to be a relief forever. And so that's why the active conversation, what is the goal? Let's clarify the goal in having, transfusion safety and symptom management be a part of the conversation with the lab. What are some, if people are listening, what are some practical tips that they can do? Obviously understand, read, and be engaged in what's going on in your political circles around you, so that you can advocate from a laboratory lens and perspective. But what else do you think our listeners can do on this topic?
I have one basic suggestion.
Yeah.
What is that?
If you have, you're going to know what it is. If you have the option, donate a unit.
Yeah.
Be a donor. That way you can provide more access to more people. If you have that option, I'd say that would be the number one thing that you could do, and that would make every blood banker listening very happy. But I feel like Stephanie and Melody have some good suggestions as well.
Well, no, I'm just going to give my standard like blood transfusion tidbit, which is 1 in 10 people in the US donate, but 1 in 4 will need a transfusion in their lifetime.
Mhm.
So like you should think about that. Like it's could happen to any of us. And then think about palliative. Like what if this was, again, we always talk about this better life for mom and dad. If that was your mom or your dad who's at their end of life management and they really need a little bit of a boost so that they can attend your child's graduation, like would you want that access there? And I think most of us would say yes, you know?
And hopefully one day they'll finally work out artificial blood. But they keep talking about that. I think 50 years from now, we're still going to be talking about that. So if you haven't, listeners, if you haven't looked at artificial blood, put it in Google. It's kind of a cool concept, but it's still got a long way to go. So we still need to keep having these conversations. And
Yay, AI blood.
AI blood. As
Oh
it.
my gosh. What about that?
Oh.
Well, this is like such a heavy conversation, but thank you guys for having it with me tonight. And like, obviously we want to keep the conversation going with our listeners. And yeah, Steph, what do you got? Any thoughts, any closing thoughts?
In closing, stay scientific, stay curious. Like Dr. Nelson will tell us all, stay curious and continue to follow us and chime in the comments. Let us know what you think. Let us know from your laboratory lens, from your healthcare lens, what you've encountered or what you think, or if you've read up on this act and, you know, how do you think it will impact your life today in the lab? And let's continue the conversation. We're so excited for our listeners who are becoming engaged and becoming advocates in their local communities and in, on the national platforms of what's going on in our cities and our states that might impact the work that we do.